Medic Level Up here, and we're back again with another video. Today's video is going to be slightly different. We're going to be doing some ECG interpretation. Let's dive in. Before you watch this video, I would highly recommend that you'll go through videos 1 through 15 on my channel in order to get a better understanding of what we're going to be talking about today. Ready? Let's go. As always, I would advocate a systemic approach to interpreting these ECGs, and I will take you through that. There's 14 things that you need to look for on an ECG. Standardization, rate, rhythm, P wave, the PR interval, the Q waves, the QRS complex's duration, the QRS complex's height, the ST segment, the T wave, the QTC interval, presence of U waves, the R wave progression, and the axis. After a while, all of these 14 things will become second nature, and you won't have to go through this checklist every single time. Here's these 14 things, and we'll use all of these in order to interpret our ECGs. Now that you have the power, let's put all of this to use. Here's the first ECG. Pause the video, make your assessment, and then we'll move forward. The standardization was normal. The rate is regular at 83 beats per minute. Normal sinus rhythm with 1-to-1 conduction of P waves and QRS complexes. Normal morphology of the P wave. The PR interval was less than 200 milliseconds. The QRS complex duration was narrow. The QRS complexes were of regular height throughout the ECG. Q waves were only seen in lead 3. And the ST segment was isoelectric. The T wave was flattened in isolation in lead 3. There were no U waves. The QTC interval using the Bazet formula was 423 milliseconds, which is normal. The R wave progression was normal in the precordial chest leads. And the axis was normal as well. That was a normal ECG. Let's move forward. What do you think about this one? Let's not go through all of these. I want you to focus on the P wave over here. The P wave morphology was bifid in lead 2. It was predominantly negative in lead V1. And we know that means it's a left atrial abnormality. This was a normal ECG apart from the possibility of a left atrial abnormality. What do you guys think of this one? Go on. Go through the 14 things and tell me what you see. If we focus on these two things, we'll be able to make our diagnosis. The QRS duration was more than 126 milliseconds. It was 3 small boxes. The morphology of V1 and V6 was very much typical of a right bundle branch block pattern, but the axis quite wasn't conforming to a RBB. Well, there could be concomitant left ventricular hypertrophy or an anterior fascicular block. In either way, the patient needs an echo. What do you think the subtle finding on this ECG is? When you go through all of these 14 things, what you'll notice is that the ST segment and the T waves were abnormal. There was elevation in leads A1 and AVL, V2 and V6, and there was T wave inversions in lead AVL, V4, V6. What do you think the culprit artery was over here? Most likely the proximal left anterior descending. This was a STEMI. What do you think of this ECG? Go through all of those 14 things again. You'll notice something about the ST segment and the T wave. The ST segments were depressed globally. There was elevation in AVR. Is this subendocardial ischemia, or was this a STEMI? Well, the most important thing is missing from an ECG, and in the words of the famous Sherlock Holmes,
data, 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 I cannot make bricks without clay.
If your patient is squeezing onto his chest, he's in severe pain, you know that it's an STEMI. But on the other hand, if your patient is giving you a thumbs up and he's on the phone, you know that it was a strain pattern, ST depressions with asymmetric P-wave inversions. Let's move on. What's going on over here? When you go through all of those 14 things, you'll notice that the ST segment was off a little bit over here. There was ST elevation in the inferior leads, depression in the lateral leads, and depression in the septal leads. Here's a mirror image of V1 and V2, and you can clearly see that there's ST segment elevation in these leads, which signifies that this could be an inferior and posterior STEMI. What do you think the culprit artery is over here? The right coronary artery. What do you think is going on over here? When you do a complete analysis of the previous ECG, you will find out that there is something wrong about the T wave and the R wave progression. Essentially, you have deeply symmetric T wave inversions in the precordial leads, and you have a preserved R wave progression. Again, you need to take a look at the history of this patient. If this patient was complaining of cardiac pain previously and is now pain-free during this ECG, it's a Wellens syndrome. What's the next step? Well, certainly not this.
Oh my God! Okay, it's happening. Everybody stay calm.
What's the
Everybody
procedure,
stay
everyone?
calm.
What's the procedure?
Stay calm.
Wait.
Everybody calm down.
What do you think is going on over here? While making your analysis, think of the fact that the patient came in with chest pain. You'll be able to tell what was wrong with the ST segment. It was elevated in the anterior septal leads, and it was a STEMI. The culprit artery was most likely the distal LAD. What do you think is going on over here? If you go through all of the 14 things that we discussed about, you will notice that the QRS complex duration and the axis is what you need to look at. A predominantly negative RS complex in V1, lateral leads showing predominantly positive complexes. If you do the axis, you can use any of the 3 methods listed over here, and you will notice that this was in fact a left bundle branch block.
One more. How we get one more? One more.
Okay, promise. Final ECG. Let's go through that ECG. I want you to go through all 14 things this time. Normal standardization, normal rate, rhythm is sinus, the P-wave appeared bifid in the inferior leads, the PR interval was more than 200 milliseconds. The QRS complex duration and height was normal. There were no Q waves. The ST segment was isoelectric. T waves were normal. There was no U wave. The QTC interval using the Bazet formula was 376 milliseconds, which is normal. Normal R wave progression, with maybe some wrong lead placement of V6. The axis was anywhere between -30 to +30 degrees. What's the final diagnosis? A first degree AV block and a possible left atrial abnormality. If you go through these 14 things repeatedly, you will not miss anything. I know. You guys are probably like this at the moment. Well, thankfully, we're done. That's all for today. Let me know in the comments section if this was helpful or not. Don't forget to like, share, and subscribe to the channel. And have a good day.